this is a case from skin and subcutaneous tissue. So there are multiple draining sinuses visible in the right axilla of the patient with some scarring. Okay, so he's a 29-year-old male who is a non-smoker who presented to OPD with one history of intermittent discharge from left axilla. Medical, surgical, and family history are unremarkable. He reported that the wound exhibited intermittent discharge that had turbid appearance with and it was mixed with blood. He has a long history of deodorant use and multiple time antibiotics intake. So we have these questions: diagnosis, how to investigate the patient, staging or grading, and then management. So before discussing this case, so we are going to discuss today hidradenitis suppurativa. So this hidradenitis suppurativa, this hidradenitis word, so it is from Greek word hydros, which means sweat, and aden, which means gland. So this is suppurative inflammation of sweat gland. Okay, so this is a chronic inflammatory condition. So also known as acne inversa or Verneuil's disease. Okay, so this is important. Now so hidradenitis is thought to be the chronic inflammatory suppurative inflammatory condition of sweat glands, but the modern concept is that it is chronic follicular occlusive disease involving follicular portion of folliculopilosebaceous unit. So FPSU is folliculopilosebaceous unit. Fine. Now what are the sites of involvement of hidradenitis suppurativa? So first thing is, most important, is intertriginous area. So most common site is axilla. So most common site is axilla. Okay, then other sites are groin, perianal, perineal, then inner thigh. Okay, then inframammary, and then buttocks, pubic area, scrotum, vulva, and trunk. And less commonly it is seen in scalp and retroauricular area. Okay, so less commonly seen in scalp and retroauricular area. So what basically is the clinical manifestation of this hidradenitis suppurativa? So there are recurrent inflamed nodules and abscess. Okay, recurrent inflamed nodules and abscess. So then they form draining tunnels, so which was previously known as fistula and sinus. Okay, then there is formation of bands of severe scar formation. Okay, so this is basically clinical manifestation of hidradenitis suppurativa. Okay, there is pain also, there is malodor also, and drainage. So drainage of pus or blood tinged fluid. Okay, then important thing is disfigurement is there. and ultimately there is psychosocial impact. So this all is seen as clinical manifestation of hidradenitis suppurativa. Okay, then it is also misdiagnosed as recurrent folliculitis or recurrent folliculosis or boils. Okay, so prevalence is 1 to 4%. It is seen in 1 to 4%, and age is puberty to 40 years. Okay, so it is seen mostly in second and third decade. So second and third decade, and most commonly seen in females than males. Then we come to pathogenesis. So pathogenesis. So initially it was thought that there is apocrine gland involvement. Now the theory, which is based upon folliculopilosebaceous unit, so it says that it is follicle centered theory. So mechanism is there is follicular occlusion first. So follicular occlusion is, this is initial development of hidradenitis suppurativa lesions. Okay, so this is most likely event, and after that there is follicular rupture and associated immune response. Then this associated immune response, this is the important event in development of hidradenitis suppurativa. Okay, so this is important, and follicular occlusion was first. Follicular occlusion was first. Okay, then we come to associated factors. Okay, associated factors. So what are the associated factors here? First is genetic susceptibility. Okay, then second is mechanical stress on skin. Then third is obesity, smoking, dietary habits, diet, hormonal. Okay, so then is bacterial. So this bacteria as an associated factor is controversial. Okay, as we see in early unruptured lesions, the fluid is sterile if you do culture sensitivity, whereas in older lesions which are ruptured, in those lesions you will find bacteria. Older ruptured lesions. So besides these, if you see skin tunnels also, skin tunnels, in those also you find bacteria. So mostly bacteria which are seen is coagulase negative Staph aureus, streptococcus, gram negative rods, and anaerobes. Okay, so these microorganisms you see there. Then some drugs are also associated. So androgen or associated with hidradenitis suppurativa. So patient who are taking treatment on OCPs which contain androgen progestins like IM, MDPA, then levonorgestrel in IUDs. So these, they precipitate or worsen the hidradenitis suppurativa. Okay, they precipitate or worsens the presentation and symptom of hidradenitis suppurativa. Okay, then there is lithium therapy that is also involved. One more thing to note, that this hidradenitis suppurativa, so it presents as adverse effect of some drug like anti-tumor tumor necrosis factor alpha, then biological treatment for other chronic conditions. Okay, so other chronic condition. Fine. So then coming to how sex is related to hidradenitis suppurativa. So as I already said, in females it is more common. So sites are also different in male and female. So mostly if you see groin, that is involved in both male and female. Then is thigh, both females and males. Whereas upper inner thigh involvement in females is more as compared to males. Then if you talk about axilla, so both females and males. Then if you talk about chest, that mammary area and inframammary folds, so mostly seen in females. Okay, then if you talk about perineal and perianal area, so they are seen mostly involved in males. And then if you see buttock in both females and males, then gluteal cleft, both females and males. So besides, if the involvement is in non-intertriginous area, okay, so it is not related to sex. Okay, it is not related to sex. Then so like non-intertriginous area like belt line, so this is because of pressure. Okay, this is because of mechanical stress or pressure on the skin. Then waistband, abdominal folds, then we have this brassiere straps, then bands. Okay, so these are not associated with, not related to sexual orientation. Okay, then what are the lesions you find in this hidradenitis suppurativa? The first lesion you find, that is inflammatory nodules. So inflammatory nodules, so they last from days to months. Okay, then after this you can find skin tunnels, so previously known as fistula and sinus. So they last from months to years. And then there are comedones, so they are double or multi-headed comedones. Okay, double or multi-headed, so they are also known as tombstone comedones. And they reflect the end stage damage to pilosebaceous unit. Okay, so this is tombstone comedones. Fine. Then we have closed comedones also. So these are not related to diagnosis. So you can find closed comedone also, but these are not related to diagnosis. So after that, what you find is scarring. Fine. Then so there is a staging system. Okay, there is clinical staging system. Hurley's clinical staging system. So Hurley clinical staging system. So in which we divide it into three stages or grades. Grade stage 1, stage 2 and stage 3. Stage 1 is basically abscess formation. Okay, so you find single or multiple abscess without skin tunnels. Okay, without skin tunnels or scarring. Whereas in stage 2 you find recurrent abscess with skin tunnels and scarring. Okay, then one more thing to note here is that they can be single, they can be multiple, widely spread. Okay, so then we have diffuse involvement. Fine, diffuse or almost diffuse involvement. So there are multiple interconnected abscesses, tunnels, okay, across entire area. So this is Hurley clinical stage 3. Okay, then if you talk about associated syndromes in hidradenitis suppurativa, so first is metabolic syndrome and related disorders. Okay, metabolic syndrome. So we have diabetes mellitus, we have obesity, then we have insulin resistance, then we have dyslipidemia, then we have hypertension, we have cerebrovascular accident, and then we have myocardial infarction. Okay, so these all are associated with metabolic syndrome. Second is IBD, inflammatory bowel disease, and predominantly Crohn's disease. Then third is acne. So they are very severe in hidradenitis suppurativa. Okay, acne. And then fourth is, so there is a triad basically. There is a triad along with hidradenitis suppurativa, which completes a tetrad. Okay, then it includes, first is acne conglobata, second is dissecting cellulitis of scalp, third is pilonidal sinus, and then fourth is hidradenitis suppurativa. Okay, so this completes a tetrad. Then we have other things like PAPSH syndrome, which includes pyogenic porogenic arthritis, pyoderma gangrenosum, acne, hidradenitis suppurativa. Okay, so this is PAPASH. Okay, then another term is PASH, which includes pyoderma gangrenosum, acne, and hidradenitis suppurativa. Okay, so this is PASH. Fine. Then diagnosis. So diagnosis is mainly clinical diagnosis. Okay, so because we have typical lesions, as explained earlier, typical lesions, we have typical locations already explained, and then there is relapse and chronicity. Okay, so then what about investigation? So whether investigations are required or not. So what is done usually is skin biopsy. So skin biopsy is done only when you suspect any malignancy. Okay, like squamous cell carcinoma, you suspect malignancy, you do skin biopsy. Otherwise usually it is not done. Then is culture. So culture is usually not done. So when you suspect infectious thing, or in case of severe pus discharge, okay, you can do culture. So as we know, in early lesions their culture will be sterile. In delayed lesions and the lesions which are ruptured, in those cases you find culture positivity, and then microorganisms which are involved, and you can start those antibiotics. Okay, then imaging. Similarly, imaging is also not necessary. So you can go for ultrasonography in case of subclinical disease to look for extent also. And then is MRI. Again, MRI, you can go in case of extensive anogenital disease. Okay, extensive anogenital disease. So otherwise, so there is no requirement of investigation. This is clinical diagnosis. Fine. What are the differential diagnosis? So if we talk about differential diagnosis, the first thing is follicular pyoderma. Fine. So we have folliculitis, we have furuncles, we have carbuncle. Then second is acne vulgaris. Okay, acne vulgaris. Then third is pilonidal sinus. Fine, pilonidal sinus. And then fourth is Crohn's disease. Fine, Crohn's disease. So you will find symptoms of Crohn's disease also. Fine. So this will be mostly seen in disease involving the perineal or perianal area. Okay. Then one more is granuloma inguinale. So organism which is responsible here is Klebsiella granulomatus. This is also known as donovenosis. Okay. What are the complications? Fine. So complication is first is stricture contractures. Then is lymphedema. So usually you find in case of vulval and genital hidradenitis suppurativa, you find lymphedema. Okay, lymphedema of vulva, thighs, okay, and pubic area. Then third is malaise, and then patient eventually go into depression and suicidal tendencies. Fine. So then we have anemia, then associated hypergammaglobulinemia, then hypoproteinemia and amyloidosis. Okay, so these all. Then you can find epidural abscesses also. You can find sacral osteomyelitis. Then you can find arthritis, and of course squamous cell carcinoma, non-healing lesions, squamous cell carcinoma. Fine. So then coming to the treatment of hidradenitis suppurativa. So important thing is you assess the disease severity. Okay, so you assess the disease severity first, and side by side you educate the patient, you support them, then you do wound and skin care, and then you do pain management. So wherever there is pain, and you assess and manage the comorbidity. Okay, comorbidity. So you assess and manage it. Fine. So then important thing here is, so either there will be lesions without scarring or skin tunnels, or there can be lesions with scarring and skin tunnels. Okay, with scarring and skin tunnels. So what you do, so in both the cases you can start intralesional corticosteroids and punch debridement. Okay, then you can use topical resorcinol, and you can also go for IND if required. systemic glucocorticoids, and then you can also do surgical deroofing wherever it is required, surgical deroofing and wild excision, okay, in extensive disease. But what is specific for these? Without scarring, you start oral doxycycline, and you can also add anti-androgens and metformin. Fine. And then you assess after 3 months. Okay, so assessment is done after 3 months. Whereas in this case, with scarring and skin tunnels, so besides this intralesional corticosteroid punch, debridement, resorcinol, topical, IND, systemic glucocorticoids, then surgical deroofing and wide excision. So you start doxycycline or clindamycin and rifampin with or without anti-androgens or metformin. Okay, so this is how you start. Fine. So if in this case there is satisfactory response, so you can stop doxycycline. Fine. And you can continue anti-androgens and metformin. Continue anti-androgens and metformin. Fine. Then again you do follow-ups. So if there is progressive improvement, so what you do? You continue treatment and you reassess after 2 to 3 months. 2 to 3 months. Okay, fine. And the third was if there is no response or poor response. So if there is poor response or after this reassessment there is unsatisfactory response, so you stop doxycycline. Fine. You stopped doxycycline and then you can start one of these. Oral anti-androgens and metformin if not used earlier. Second, you can start oral clindamycin and rifampin. You can start acitretin, and this should not be given in potential childbearing patients. Okay, so this is important, should not be given in potential childbearing patients. So then if you see this one with scarring and skin tunnels, and if in this case there is satisfactory response, so you stop antibiotic and you can continue with anti-androgen and metformin. Okay, then you follow up, and if there is progressive improvement, you can continue antibiotics and anti-androgen and metformin and follow up after 3 months. Fine. And third thing was if there is poor response. So if there is poor response, then what you do? Or if there is unsatisfactory response after this. Fine. So in this also you can also start oral dapsone. Fine. So if there was unsatisfactory response after progressive improvement and follow up after 3 months, or there is poor response initially, then you stop antibiotics. Okay, so you have to start immunotherapy, you start adalimumab. So alternatives we have bimekizumab, infliximab, and acitretin. Okay. Then also you assess the need for surgical intervention. Again, you assess the need for surgical intervention. Okay. That is deroofing you can do. Deroofing. Okay. And you have to continue this for 12 to 16 weeks. And then you assess the response. Fine. So this is how. Then if there is satisfactory response, you continue treatment and you add anti-androgen or metformin if not given earlier. And if there is poor response, so you switch over to ustekinumab and bimekizumab, anakinra, and IV ertapenem. Okay, so you switch over to these things. Fine. So this is how you treat hidradenitis suppurativa. There are other treatment modalities also. Okay, others. So we have Nd:YAG laser. Then we have a combination of rifampin, moxifloxacin, and metronidazole. Then we have phosphodiesterase esterase 4 inhibitor like apremilast. Then you can add zinc supplements. Okay, zinc supplements. You can start with oral retinoids like isotretinoin, retinoids, and others. There are others also like fumarates, fumarates, vitamin D3, vitamin D3. So this is D3. Then ionizing radiation and photodynamic therapy. Okay, so now coming to the question, so which was asked in that case. So first was diagnosis. So diagnosis is hidradenitis suppurativa. How to investigate patients? So you do clinical examination, that is enough. So if required, you can go for culture, you can go for biopsy, you can go for radiological investigations. Okay, staging or grading, we have Hurley grading system. So this is most likely stage 2 in this case. What is the management? So management I have discussed in details.